to our next speaker, Dr. Gaurav Luthra, who is going to talk on the very much raging topic, Contoura vision. It's all over the place, and we all of us have been forced to remember that. But there are a lot of value attached to it. So we actually need to know what is the stance of Contoura Lasik and how it contributes in refractive surgery truly. So I hope Dr. Gaurav is going to give us a clear perception of the role of Contoura Lasik. यहाँ कोई fan नहीं है क्या?
नहीं.
हाँ? Dr. Gaurav Luthra again needs no introduction. He's a very leading cataract refractive surgeon of the country and has been doing amazing work in refractive surgery from Dehradun. And he's going to tell us something so relevant for us about Contoura Lasik.
Thank you, Dr. Chitra, for making me a part of your course. And it's always interesting because your course is always very engaging. And you had asked me to speak on Contoura, which I've been doing for a few years. Let's try to see and understand where to use Contoura in our practice. So Contour, as we all understand, is representing the shape or form. So that's what we are doing with Contoura LASIK, that trying to correct the topography of the cornea by doing a topography guided treatment. And I'm sure that if we have all refractive surgeons sitting here, they would be aware of the fact that we do wavefront optimized as one of the most predominant forms of laser correction. And then, many years back, wavefront guided treatments took fancy for all of us. And, somewhere way back in 2005 or 6, we all started playing with abrometry-assisted treatments with wavefront guided treatments. But very soon we realized that it would work only for a few percentage of patients. And over time, we started doing Q value adjustments, giving them, enhanced Q values and playing with that. So the Q value based the FCAT treatments on the Wavelight platform and also on the other platforms in different names. And then last few years, we've understood that, many of these corneal aberrations are actually on the cornea. So it would be best suited to correct them with topography-guided treatments, which have been around for more than 10, 15 years as well. But Contoura was born when FDA did a study for the US markets. The Alcon did a study for FDA trying to see that whether topography-guided treatments were of any benefit on virgin eyes, which means not even corneally aberrated eyes, but on virgin eyes. And they were surprised to find that, the topography-guided treatments on virgin eyes showed marginally better results than the wavefront optimized, and that was not even on aberrated eyes. So that's how Contoura was born and got that fancy name of Contoura, which had always been around for many, many years before that, and we had been doing topo-guided treatments even before. And this is how it works. You do a topography on the Wavelight laser with the topo vario topolizer, and then you import these maps into the Wavelight machine and do the calculations, and then you can fire that treatment using the excimer laser. And Contoura is basically a topo-guided treatment for virgin corneas, and you can of course do it for aberrated corneas as well. And we've already spoken of how Contoura was born. So it tends to treat all the many of the pre-existing higher order aberrations and prevents induction of new higher order aberrations. And it's based on corneal topography, and it combines with the wavefront optimized treatment as well. And it is centered on the corneal vertex, so it's not influenced by the pupil centroid shift. So it tends to be much, much better in its application. So most lasers will fire on the pupil center. This will fire on the vertex of the cornea. And how it is different from wavefront optimized is that optimized is basically based only on the refractive prescription of the patient and the keratometric reading of the patient that helps decide the treatment protocol, whereas Contoura will combine the prescription along with the topography maps and then put together a treatment, so that improves the quality of vision, which we all talk about. And of course, Contoura vision is very different from wavefront guided because we understand that 70% of the refractive errors are from the cornea, so correcting them will be much more important. Customized wavefront guided treatments would also include the lenticular aberrations. So if you have lenticular aberrations and you're trying to correct them on the cornea, it seems to be counterintuitive anyway. So Contoura, when it was born, was by Alcon in 2017. They advised that treatment should be calculated based on patient's manifest refraction. And by ignoring the refractive effect of the topographic irregularities, surgeons were not getting great outcomes. So then came the TMRs when John Kalanopoulos developed this. And in this, they were basically relying totally on the topographic manifest refraction, but it led to, again, not great results. So this, when Contoura had teething troubles initially because the nomograms which Alcon was trying to propose were not giving us amazing results, and it took a long time before we understood that how to go about it. So who are the ideal candidates for Contoura? It says 18 and older, but this is when Contoura was, kind of approved by the FDA. But frankly, today I don't like to operate anybody below 21, and that too with stable refraction for at least 2-3 years. And Contoura is usually done for virgin eyes and can be done for myopia and astigmatism, as is mentioned there. The main thing is that you should be having great maps. So if you don't have great topography maps, you will not be able to do a good Contoura treatment. So there should be no dry spots, and there should be no data losses. There should be proper exposure. And you should not do Contoura if you don't have good maps. We are trying to do enhancements, or you're doing stromal scars or PTK, or if there are significant lenticular changes or early cataract, because you'll end up making a mess of it. So as we go stepwise on how we can do Contoura treatments, the step one is to get a great topography, as I told you. And this would be a good topography scan, as you can see. This, with lots of areas missing out over there, would not be a great topography scan because much of the iris is actually covered with different artifacts. So if you have poor topography scans, the machine will usually tell you that you don't have great scans, and it basically uses 5 to 6 scans, and if all of them are good, then it tries to average them out and then forms a treatment plan for you. And but then you come to the planning when the data is sent to the machine, and we get a set of values. You can see this comes up on your excimer laser. I will not go into details because this talk is not on how you would want to do Contoura, but when to do Contoura. But it's important to know that how the machine does it. So once the data is imported, then you can just kind of neutralize all the refractive error and see what the machine is actually going to do. This you can do by putting 0 at the final treatment plan. So what it shows eventually here is what the aberrations are going to be corrected, and you should have a look at this, what is the maximum and the minimum it is going to do, and the talus as well. So off late we have moved on. This is how the treatment plan looks. And now the decision making on whether if the axis and everything coincides, it becomes much easier. If your topographic astigmatism and your manifest astigmatism is matching, again, it becomes much easier to go ahead with the treatment. But when they don't match is when you have to actually take a decision on what you're going to do. And this is where, this new engine, software engine, which we use as Forcities, has come very useful, because it tends to simplify and make it make simple kind of a thing for you to understand how to go ahead with this treatment planning, because it works on the concept of the talus. Basically, talus is the irregularities on the cornea different from the normal corneal shape. So it's the secondary elevations on the cornea which all are having a refractive effect and need to be corrected. And the planning software is free software for Indians, at least, made by Mark, I'm forgetting his name, Lobanov, and he's been kind enough to give it to many of us, and we are using it. So it basically does a vector analysis, and it takes into account 4 things: the anterior corneal astigmatism, the talus astigmatism, the posterior corneal astigmatism, and some of the internal as well, and then comes out with a treatment plan. I will not go into the complexities of that, but just to show you a case, 22-year-old male, and acceptance was -1 sphere with -6 at 20, other eye -1 with 5.25 at 155. So cyclotorsion is going to be very, very important for this patient. And if you look at the maps here, the symmetric bow ties, look at the bad maps are good. The aberrations are there, of course, but if you look at the eye trace, you'll see that the corneal aberrations are much, much higher than the internal aberrations over there. So this is an ideal case for doing a Contoura treatment, because has high astigmatism, good epithelium maps, good maps on the anterior. So what should we do? I would have done either a toric ICL, or I would have gone for a Contoura LASIK. Patient was more keen to do a LASIK procedure. Use the Forcities for the planning, and these are the taluses which come up when you feed the data. And this is the final treatment plan at the bottom. So it's taking into account your refractive error and your measured astigmatism from the topography and giving you a final plan. As you can see, the manifest is at 20 degrees. The Contoura recommended from topography is 12. The pentacam is giving anterior at 13 degrees, and the posterior cornea is at 102. So they all match up. And then this is the final treatment plan. And these work really well. We've been doing it for about 4-5 years. Contoura tends to really give well. And when it doesn't work, it tells you that don't do a Contoura here at all. It tells you to go do a wavefront optimized, and it really makes life much easier. So these were the post-op maps. Patient did extremely well. This was the right eye, and this is the left eye. Had very high quality vision with very good correction of the astigmatism as well. So I think post-op day 1, patient was 6 parts. The refraction is right at the bottom, and you can see that if you consider the kind of astigmatism he had. Coming to the finishing, I would like to finish by saying that Forcities has been a great transformation for us. We were struggling with Contoura right in the beginning. It has helped us improve our outcomes. And it also tells you when to use Contoura and when to switch to wavefront optimize. And quality data capture is the key, and a good planning. So when somebody says I do 100 Conturas a day, you have to take it with a pinch of salt. It requires good 15 minutes or 20 minutes to do these plans sit for each patient, and then execution also takes much more time. So final conclusion, hyperopia, because it treats on visual axis, can be a good option for Contura, but it's a difficult planning on the paucities doesn't plan for hyperopia. High astigmatism with good cyclotorsion control, very high corneal aberrations, and many times now patient wants it and comes asking for Contura, although now they come asking for silk more often than Contura. Yet, some patients will come seeking Contura, and then you have no choice. If it's not doing harm to the patient, you can still go ahead. And we all understand that new technology is really helping us. And with that, thank you so much for inviting me, ma'am.
Thank you, Dr. Gaurav. Any particular question you would have to talk when you would not do a Contoura Lasik?
So there will be
Very
times.
brief.
Yeah, there will be
and
times.
I would want the next speaker, Dr. Mahipal, to.
There will be times when there will be huge disparity between what the topography picks up as the astigmatism or the aberrations, and is suggesting a totally different plan than what is your manifest. This typically will happen in suspect corneas or on corneas. There it may be a better idea to just go with a topo guided treatment rather than a paucity.
Wavefront optimized treatment. Then,
of course, wavefront optimized, but I'm talking about keratoconic corneas where there's huge irregular astigmatism. There you may do a topo guided PRK CXL, but otherwise 90% of the times, if the two things are not matching at all, which means that your Contura planning is not matching with your manifest at all, I would go with wavefront optimized. That's the take home message. Can't force a Contura treatment on every eye.
would you want to prefer to do, whenever there's more astigmatism, do you feel doing Contura is better than doing smile?
Absolutely, absolutely. So in fact, my second case, which I didn't show, was typically one where one eye we did smile and second eye we did Contura, because there the astigmatism was like much more than the sphere, and patient had great outcomes in both eyes. So with high astigmatism, which is higher than the sphere at least, I will always go for Contura than for smile in that patient.
Supposing you had cyclotorsion compensation then?
Yeah, so we do cyclotortion compensation even on smile, but I feel Contura still has slightly better outcomes. And Dr. Mahipal is still not convinced about it, even though he has a machine. But I will convince you one day.
Yes, it is. Now, I think each of the machines have their own advantage, and we should fine-tune them to the procedure which we want. And of course, before Contura came, we were doing higher cylinders and doing well with smile, but there's some kind of a precision which the Contura patients have in high cylinders. Thank you very much, Gaurav, for bringing out